General breast cancer screening. The U.S. Preventative Task Force recommends screening with mammogram biennially, meaning every 2 years, starting at age 50 up to age 75. If you're age 40 to 49, you can consider every 2 year screening, weighing the risks and benefits of doing so. For patients with a history of thoracic radiation at age 10 to 30, you get an annual mammogram and or an MRI yearly starting 10 years after the completion of the radiation or at age 40, whichever is earlier. Just be aware again of the axillary regions, which are defined in relation to the pec minor, which is shown here, pec minor. Level 1 is inferior and lateral to the pec minor. Level 2 is beneath the pec minor. Level 3 is superior and medial to the pec minor. Pathology, luminal A is ER positive, HER2 negative, low grade, low Ki67. Luminal B is ER positive, HER2 negative, high grade or high Ki67. Basal is triple negative, HER2-like is ER positive and HER2 positive. These impact the ipsilateral breast tumor recurrence rates after radiation. HER2 positive is defined as IHC3+ or FISH amplification of greater than or equal to 2. Medullary cancers are typically ER/PR positive and have good local control, rarely have nodal involvement. Apocrine cancers are typically ER/PR negative with an intermediate prognosis. Pleomorphic lobular are usually bad, high grade. Metaplastic are usually bad and high grade. Extensive intraductal component, or EIC, means DCIS is greater than 25% of the invasive ductal carcinoma specimen. PARC data, an extensive positive margin, usually results in local recurrence rates of 27%. A focally positive margin often results in local recurrence rates of 14%, but this can be reduced to 8% when receiving chemotherapy. A negative margin has local recurrence rates of 7%. The ASTRO consensus guidelines of 2014 say that a positive margin is ink on the invasive carcinoma. There's a greater than twofold increase in ipsilateral breast tumor recurrence, which is not nullified by boost, chemo, or biology with a positive margin. Wider margin width does not lower ipsilateral breast tumor recurrence. We're no longer differentiating between a close and negative margin. Note that this is different from DCIS, where you do want greater than 2 millimeter margins. LCIS at a margin is no indication for re-excision. Negative margins, no tumor on ink for invasive, greater than or equal to 2 millimeters for DCIS. If a sentinel node biopsy shows microscopic disease, you treat as a node-negative patient. In terms of workup, initial presentation, you want to do bilateral screening mammogram or a palpable mass. Mammogram evaluation, just remember there's craniocaudal, which shows the outer per convention versus the medial. Just zoom on this a little bit more. Bilateral screening mammogram, palpable mass. Mammogram eval, again, craniocaudal shows outer versus medial. The convention is that the top is the lateral as designated here, and wherever the craniocaudal marker is lateral. This should show the nipple, and the marker is on the lateral side. Again, the medial lateral oblique is the view here. The convention, the medial lateral oblique, is that the convention is the top is superior. The marker is wherever the MLO marker is. This again shows the superior and inferior view. This is angled at 30 to 60%. You need to see the pec major, which you can here on the film down to the level of the nipple. It includes the axillary tail. The BioRad screening system. BioRad is breast imaging and reporting data system. It's scored from 0 to 6. 0 is incomplete. You need additional imaging. 1 is negative. Just get routine screening. 2 is benign routine screening. 3 is probably benign, but you need a 6-month follow-up. There's a less than 2% risk. Suspicious is 4. You need biopsy. There's a 3 to 95% risk. 5 is highly suggestive of malignancy, so you need a biopsy. There's a greater than 95% risk. And 6 is no malignancy. In terms of H&P, attention to onset, duration, prior mammograms, pain, nipple discharge, family history, gynecologic history, prior radiation, physical exam, do bilateral bipositional breast exam and node exam. Imaging, sent for diagnostic mammogram and ultrasound. Spot compression for mass and magnification views for calcs. Ultrasound, a hypoechoic mass with uneven borders and posterior shadowing is often how this presents. An MRI with a breast coil is optional. This altered surgical outcomes in 33%, 3% detect an occult primary in the contralateral breast per the Akron study. JCO 2014 meta-analysis, there's no difference in local recurrence or distant mets with the use of MRI. It's okay for an occult primary to assess the response to neoadjuvant chemo or for multifocal or multicentric disease. Labs, CBC, CMP, LFTs, pregnancy test, biopsy. Core biopsy, you can get a stereotactic versus ultrasound guided, whichever modality the breast tumor is detected by. The alternative is an excisional biopsy with needle localization. This is more invasive approach, and an FNA of any clinically positive nodes. Other workup for symptoms are stage 3A. Systemic workup with a CT chest, abdomen, pelvis, or a PET CT or a bone scan. Genetic referral for patients with breast cancer per the NCCN. Triple negative less than or equal to 60 years old. Any breast cancer less than or equal to 50 years old. A family member with a BRCA mutation. Multiple breast primaries. A male breast cancer. Greater than or equal to 1 first degree blood relative with breast cancer. Blood relative first to third degree with breast cancer at less than or equal to 50 years old. Greater than 1 blood relative with ovarian cancer at any age, greater than 2 blood relatives with breast cancer or pancreatic cancer at any age, or from population at increased risk. Fertility counseling if the patient is premenopausal. BRCA quiz items, risk of breast cancer is 50% and ovarian is 25%. BRCA1 is greater than BRCA2. In-service says lifetime risk of ovarian is 30 to 70% for BRCA1. Prophylactic bilateral mastectomy and BSO reduces breast and ovarian risk by 90%. The alternative here is breast conservation and radiation with prophylactic TAH, BSO, and tamoxifen for contralateral risk reduction by 30 to 40%, with treatment cause-specific survival is similar to non-BRCA patients. In terms of staging, the T staging, TIS, DCIS, LCIS, and Paget's, T1 is less than or equal to 2 centimeters. T1 MIC is less than or equal to 1 millimeter, which I have as less than a penny. T1A is 1 to 5 millimeters, penny to a nickel, including the nickel. T1B is 6 to 10 millimeters, nickel to a dime, including the dime. T1C is 11 to 20 millimeters, dime to John Paul Jones. Again, I don't know where this 20 John Paul Jones comes from. T2 is 2.1 to 5 centimeters. T2 starts at 2, John Paul Jones to Kennedy half cent. T3 is greater than 5 centimeters. T4A is chest wall invasion, not including the pec. T4B is edema with peau d'orange, ulceration, and ipsilateral skin nodules. T4C is a combination of T4A and T4B. T4D is inflammatory breast cancer, which is a clinical diagnosis of erythema and edema of at least a third of the breast with rapid development in at least 6 months. No more than 6 months. Generalized induration in the presence or absence of the mass, biopsy-proven malignancy. Nodal staging, clinical nodal staging, and pathologic nodal staging. Clinically, N1 is ipsilateral levels 1 through 2, which are mobile. Clinically, N2A is ipsilateral level 1 to 2, but fixed. Clinical N2B is ipsilateral IMNs only. Clinical N3A is infraclav with or without level 1 and 2 involvement. N3B is IMN and level 1 and or 2 involvement, and N3C is supraclav. Pathologic nodal staging, pathologic N0, I plus is IHC, pathologic N0 molecular plus is detected by PCR. Pathologic N1MI is greater than 0.2 millimeters per 200 cells, but less than 2 millimeters. N1A is 1 to 3 axillary nodes. N1B is an IMN, only sentinel node positive, not clinically detected. N1C is 1 to 3 axillary nodes and a sentinel node positive IMN. N2A is 4 to 9 axillary nodes. N2B is IMN only that's clinically detected. N3A is greater than or equal to 10 or infraclavicular disease. N3B is IMN clinically detected and axilla or greater than 3 axillary nodes and an IMN positive on a sentinel node. N3C is supraclavicular disease. In terms of M stage, CM, 0, I plus is circulating metastatic tumor cells in the blood or found in other tissue that's less than 0.2 millimeters. Overall stage, T1N0 is 1A, T1N1-MYC is 1B, T1N1 or T2N0 is stage 2A, T2N1 or T3N0 is stage 2B, T3 node positive or N2 is stage 3A, T4 is 3B, N3 is stage 3C. Pec invasion versus true chest wall invasion. If on flexing the mass is fixed, but on relaxing it's mobile, then it's pec only. If true chest wall, it is always fixed. Inoperable cancers for which you consider neoadjuvant treatment are arm edema, satellite skin nodules, supracleft disease, or inflammatory. BRCA1 increases the likelihood of triple negative breast cancer, increased risk of contralateral breast cancer in BRCA, increased risk of second ipsilateral breast cancer in BRCA patients with breast conservation. Bilateral mastectomy and BSO decreases that risk by 90%. Toxicity and follow-up, overall survival at 5 years for stage 1 is 90%, stage 2A is 80%, stage 2B is 75%, stage 3A is 66%, stage 3B, so a T4 tumor is 40%, and stage 3C, N3 is 50%. Stage 1, less than 5% local failure and 95% overall survival at 8 years. Stage 2 and 3, less than 10% local failure at 5 years and less than 30% breast cancer mortality at 15 years per the EBC-TCG meta-analysis. Invasive lobular with similar prognosis as ductal. Isolated tumor cells are less than 0.2 millimeters and they behave like pathologically no-negative. Micromets have a prognosis between PN0 and macromets. Axillary recurrence in an undissected breast, the risk is 20% for NSABP04. If greater than 10 nodes are taken, the risk is less than 1% for NSABP04. If you have a suboptimal dissection, the risk is 8% for the Danish study. If radiation is done after suboptimal dissection, the risk is 2% in the Danish study. Toxicity, skin toxicity is the most common. It occurs in 30 to 50%. Late cosmetic issues occur in 20%. Pneumonitis with tangents is 1%, with 3-field is 3%, and then radiation with AC plus T is 9%. So chemo increases the risk of pneumonitis. Cardiac side effects are 1 to 4%, depending on the heart dose, the LAD dose, and the use of chemotherapy. There's a relative risk of 7% per 1 mean per gray, or 7% increase mean per 1 gray. I should say relative risk is increased 7% for every 1 gray mean dose of heart. Brachial plexopathy, lymphedema rule of 5, sentinel node biopsy plus tangents, risk of lymphedema is 5%. Sentinel node biopsy plus regional nodal irradiation, the risk is 10%. Axillary lymph node dissection 10%. Axillary lymph node dissection and tangents is 15 to 20%. Axillary lymph node and regional nodal irradiation is 25%. Risk of rib fracture, secondary malignancy is less than 1%, but the risk of sarcoma is 0.2% at 10 years. If you get post-mastectomy radiation, there's a 30% complication rate: tenderness, capsular contraction, poor cosmesis, upward movement, cellulitis, and implant failure. Radiation dermatitis, CTCA grading. Grade 1 is faint erythema or dry desquamation. Grade 2 is moderate to brisk erythema, patchy, moist desquamation confined to the folds or creases with moderate edema. Grade 3 is moist desquamation in areas other than the folds or creases, bleeding induced by minor trauma or abrasion. Grade 4 is life-threatening with skin necrosis or ulceration of full-thickness dermis. Skin grafting is needed. Grade 5 is death. Follow-up H&P every 6 to 12 months for 5 years and annually. Get a mammogram 4 to 6 months after radiation, then annually. If you're on tamoxifen, get an annual gyne exam. If on anastrozole or an AI, assess bone density. The main cause of death is distant mets.